Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Good morning, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Prevett. I'm one of our division leads in our pelvic health and our older adult division. And today is Wednesday, so we are working on Jerry on Ice. I apologize that I'm getting on here a little bit late. It was my daughter's first day of school, and what I thought was going to be a smooth, I'm just going to drop her off and she's going to be so excited to see all of her friends, turned into a very distressed 5-year-old about having to leave for school. So this emotional mama is getting on here a little bit late, but just so cool to see your kiddos grow up. Today we are going to be talking, this was actually a requested video, to talk about our role and how we manage hernia or hernia repair. If you are working with older adults, and I see this particularly in my males, I have had plenty of instances where individuals have had multiple hernia surgeries or multiple hernia repairs, whether at the same site or different sites. And this is an area where I truly believe that rehab has a huge role to play, and one that is not being utilized very commonly. So let's chat. So when we have a hernia, we have a perforation of the abdominal wall with the abdominal contents reaching out to the outside. So we are herniating past fascial tissue. And this can happen at a variety of places, though inguinal and umbilical hernias are the most common and most seen sites of herniation. Many individuals assume that with a hernia, it is automatically a surgical management strategy, but that is not always the case. Hernias are one of the most common surgeries. Over 1 million are done each year in the United States, but we have plenty of individuals who hernia repair is not a feasible option for several reasons. It could be one, that there's other aspects of multimorbidity that are more pressing or more of an issue. 2, individuals may be a surgical risk, and putting them under to get the repair done is it's just too much of a risk. The surgeon's not going to do it. Or 3, they've had multiple repairs in the past that have failed, and the idea of doing it again when the mesh or the repair has been unsuccessful is something that they choose not to do. When we're thinking about hernia repair, most commonly now we are using a biological conduit instead of some of the polypropylenes or the synthetic meshes that were used previously. That is because of, there was a whole thing with the FDA around the use of biological versus synthetic conduits. And there was a bit of a heightened risk with the synthetics. There has since been new types of grafts that have been put in that have a bit of a better safety profile. But most commonly we're seeing biological, grafts or meshes that are being done. For many individuals going through hernia repair, this is a day surgery. We have instances of sites in Ontario that hernia repair is literally all they do. And it almost, I don't want to compare this to a conveyor belt because it is individuals, but there's such a well-oiled machine with it that they can get multiple herniation repairs done in a very short amount of time. When we are thinking about hernia repair, oftentimes the idea around indications for a hernia repair is around the risk for strangulation of the tissue and a lack of blood flow that may lead to necrosis or tissue damage. And so that sense of urgency is on a sliding scale, but for many individuals that risk is relatively low, and therefore it is more of an elective type of surgery, one that is not in most cases an emergency, but individuals will like to get that herniation repaired if possible. Now, this is different than what we talk often in the pelvic health division, which is diastasis recti, which is a thinning and lengthening of the linea alba that is due to, in the geriatric division where it's not pregnancy, is oftentimes around core weakness and central adiposity. This is where individuals may try and do a sit-up and they will have that coning across their midline, but that is not the same as a herniation where there is tissues exiting the body through a hole in the abdominal wall. Let's kind of chat about the role of rehab. So one of the things that is the biggest concerns, or like what I feel like is the biggest miss in medical management of hernia, is that we don't think about the reason why these hernias often exist, right? So we need to get to the crux of why this is happening or why this continues to happen if we are really going to realistically mitigate risk for re-injury. And the main modifiable reason, right? Some individuals are going to have different collagen syntheses. Their genetics are going to predispose them more to hernias. But one of the biggest modifiable factors, there are two. One is central adiposity, especially a fast gain in weight. And two is around core strength. We know that so many of our older adults struggle with doing a sit-up. Heck, most of us struggle with doing a sit-up and being able to get up. It's a hard thing to be able to do. But underlying core weakness is a modifiable factor for hernia. It is a big role in the pre and post-operative period for rehab. When we think about all of the joints in our body, right, and our spinal column, our core canister is one of them, we have a balance between our static and dynamic supports. Our static supports being our ligaments and non-contractile tissues, and our dynamic supports being our muscles. When we have older adults who are very weak in their abdominal core wall, they push out really aggressively, and you're going to see, and they're going to hold their breath, and they're going to, you're going to maybe hear that audible breath hold, and they are going to push out against their core wall. What they are doing is that core contraction of their dynamic abdominal structures are insufficient for them to complete that activity of daily living that requires core contraction, and they are using an increase in inspiratory volume and a forced pushing out against the core canister to hit our static end fields, our fascial tissues. When we do that repetitively, and we do not have the dynamic supports helping with that activity, over and over and over again, the risk for perforation can increase. And so part of our role pre-operatively and post-operatively is one, to teach appropriate co-contraction of the abdominal wall to alleviate stress on the static support structures and boost up those dynamic supports. And secondarily is to strategically and systematically load the core wall. In the early phases post hernia repair, individuals are going to be placed on a lifting restriction, and that lifting restriction is because they are trying to reduce strain on that herniated graft, that hernia repair graft. And especially if they are pushing out against that graft when it is in its early healing phases, you can understand why these individuals are struggling with that re-injury. And so they say, just don't do it. But then what we have to do after that early protection phases is teach the proper biomechanics and gradually load up the core wall. And we do that with progressive overload. And that is not just in neutral. That is teaching in neutral co-contraction and appropriate loading with plank modifications, side plank modifications, isometrics, but then moving to rotation, side bending, and flexion extension in order for individuals to be able to engage in activities of daily living that require a lot of core support. And this is everyone, like even our individuals who are wheelchair users, they require a lot of core support to be able to sit in axial extension in their chair and not slump back and have that lack of support around their spinal column. And so we need to apply that progressive overload in order for individuals to be able to have that support. And then additionally, we can speak to that central adiposity link and how it may be a reason for the risk for re-injury or the risk of herniation. And that relative weakness in combination with that increase in adipose tissue is where many of our interventions go. If you have a person, my final tip, if you have a person who is struggling with the strengthening aspect of this and you want to bring pressure off that graft, you are going to teach them an exhale on exertion strategy because it takes the pressure in your belly and brings it down. And what that's going to do is it's going to reduce any pressure on the graft until the person is strong enough or their body is ready enough in order to be able to load that graft post hernia repair appropriately. All right. I hope you found that helpful. That was a quick, here is what we want to do with hernia repair. If you have any other questions or any requests of episodes, I had actually thought that we had done an episode on hernia repair in the past. So if you have any questions, please let us know. If you want to see us on the road, this weekend we have 2 courses. We're in Minnetonka, Minnesota. Julie's up there and I am in Mobile, Alabama. This is going to be the first time that I have ever taught in Alabama for MMOA. So I'm super excited. We are also in Bend, Oregon, next weekend, the 14th, 15th. And we have several courses going up until the end of 2024 if you need to get some of your CEUs. Otherwise, have a really wonderful week, everyone. I hope all of my parents' hearts are not breaking as kids are falling apart as you drop them off. But I hope you all enjoy the first week kind of back into routines, and we'll talk to you all soon.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.